Good evening, Malaysia and followers from around the world. October is Liver Cancer Awareness Month. Liver cancer is one of the top 10 cancers in Malaysia. It is in fact one of the top 5 causes for death among cancer patients. Despite its high numbers, liver cancer for some reason is always overshadowed by the Pink October, which is to raise awareness for breast cancer. This time, we'd like to talk more about this subject, which is now showing a lot of hope for patients with liver cancer, particularly with the advancements in treatment. So joining us tonight is renowned hepatologist, Professor Dr. Rosmawati, Mohamed, consultant hepatologist with University of Malaya Medical Center and founding co-chairperson of WHO Strategic and Technical Advisory Committee for Viral Hepatitis, both for the global and Western Pacific region. And of course, Azrul Mohamed Khalib, a prominent activist with his background in genetics and public health policy. Azrul has worked as a development and program specialist for over 20 years. He is currently the founder and chief executive officer of the Gallen Center for Health and Social Policy, an independent public policy think tank. He is also co-founder for the Code Blue Health news website, which has gained a lot of traction. Welcome, Professor Azrul. Okay, can we start the conversation with both of you? We start off with the ladies. Can you share with us why is there a need to create greater awareness on liver cancer, as it is regarded as somehow on the lower profile when it's compared to other cancers?
Yes, certainly. So there are several reasons why we need to enhance awareness on liver cancer, and I will actually at least name 3 of them. So the first, I think you've alluded to, it is one of the leading causes of cancer-related death, not just worldwide, also in Malaysia. Now, secondly, what the data has shown is that the liver cancer cases as well as death are increasing. And third, which I think is one of the most important reasons why awareness is desperately needed, is because most of the liver cancers can be prevented. So I think that's the very strong point towards having enhanced awareness on liver cancer.
Azrul, before you join in, I just want to share something as to why liver cancer means a lot to me. My father-in-law passed away because of liver cancer, and my mother-in-law, my mother-in-law is a survivor. And as for me, because I love my whiskey, okay, and my fatty food, and of course I've got a sugar level issue as well. So I always need to go and check my liver, and I begin to understand and know some of the technical terms and medical terms that have been used because of my frequent visit to the doctor to ensure that I am still okay. So I've got friends who are facing this liver cancer issue and fighting very hard against it. So I've always wondered that many of us, we've heard of other cancers, but somehow or another, there's much talk about in the public about this. Azrul, you can jump in now and share with us some of your thoughts on this.
Well, really, RealChunWai, when we look at liver cancer, I think it's really a missed opportunity. And for the reasons that Prof. Rosmawati just said just now, it's highly preventable. And when we look at the data coming from the National Cancer Registry, for example, I think it's not unfair to say it's shocking, the fact that despite it being highly preventable, we see that liver cancer is the 6th most common cancer amongst men and 8th amongst Malaysians overall. And it's not just about loving your Guinness or your whiskey and so forth. It's also about non-alcoholic fatty liver disease. And when you look at the 5-year survival rates, really, it's just really, really sad, because we see for liver cancer it's around 12%, 12.8%, and the worst being, of course, lung cancer. So, when you consider the fact that this is preventable, there should be something that can be done. Certainly, when you look at it from a public health perspective, it could be considered a failure. So, for these reasons, I think we should actually be able to, there's a lot of cancers out there. Many of them are hard to treat, but this is one which is not only treatable, but it's also preventable, especially if you catch it much, much earlier. And when you look at how late the diagnosis of liver cancer generally, and I'm sure Prof. Rose will mention this later, it's something that we can actually prevent. And you're already doing part of it, Chunwai, monitoring your fatty liver and getting screened and so forth.
Doctor, before we talk about the main risk factors related to liver cancer, from my experience, from my interaction, sharing with friends, even for my father-in-law, because of late detection, and there was a time before you have this advance in treatment, it came very fast. Most of my friends who has passed on, it was like months, 3 months, and it was gone. And it came so fast then. What would be the main risk factors that related to most cases in Malaysia, doctor?
Sure. So if you look first, what are the commonest causes or risk factors worldwide? It is hepatitis B. Nearly half or 50% of the cases are hepatitis. So similarly, in Malaysia, it is also hepatitis B. But the latest data, which is rather alarming, shows that this pattern or the causes are changing. And one of the things we actually have shown from UMMC is that this is because of the changing pattern of the fatty liver disease. So if you look at the latest data, which was just published this year from our center, the 44% or so of cases of liver cancer is due to hepatitis B, but closely behind, very closely behind now, is fatty liver, accounting for 42% of cases. And you can see that this is alarming because we have got one of the highest rate of obesity in this part of the world. And really what is trying to show us that fatty liver now, not just in Malaysia, but worldwide, is the commonest liver disease. And we have to do something drastically because there are factors which are driving the cause of fatty liver-induced liver cancer. And two of the most common are actually obesity and diabetes. So we really have to focus on what are the commonest causes. So as you rightly say, hepatitis C is also an important cause. It comes in third in terms of the causes of liver cancer in Malaysia. But really, we have to focus first on the commonest causes, which is Hep B and fatty liver in terms of prevention and control.
When you said fatty liver, what do you mean in layman's language?
Okay, so fatty liver, it just means fat going into the liver cells. And people have always associated this with alcohol consumption, alcohol excess. But this is actually important too, but a lot more important when it comes to the commonest form of liver disease these days is what is previously known as non-alcoholic fatty liver disease. But the new name now, because of this not so good a term, they have changed to metabolic dysfunction associated fatty liver disease, or MAFLD, instead of non-alcoholic fatty liver disease. So when I'm referring to fatty liver disease here, most of this I will be referring to the non-alcoholic fatty liver disease or the metabolic dysfunction related fatty liver disease.
This will be dietary consumption and I think as well as our eating habits, right?
Yeah, okay. So there are a lot of factors that actually causes it, but the two common ones, as you said, is one is the overnutrition, which means excess, the obesity and being overweight. But another one actually is diabetes itself. So these are the two most common causes. So diabetes and overweight and obesity, and I like to look at it as an expanding waist circumference is actually the cause. Because what happens is when you have fatty liver, it's just purely fat in the liver cells, but it can progress further to have the inflammation related to fat, which we call steatohepatitis. So when there's inflammation, it can progress to scarring in the liver, what we call fibrosis. And eventually the whole liver will be replaced by scar tissue. And that's when we call cirrhosis. And we must remember 90% of liver cancers occur in patients with underlying cirrhosis. That means a scarred liver.
Yes. Unfortunately, that is the term I keep on hearing every time I visit my doctor, and he showed me this X-ray. Oh God, okay. Which looks like an good excuse for my wife to say, "Can you please stop your wine and your whiskey?" Okay. Azrul, when we talk about this, our Malaysian bad eating habit. You and I, when we go to the supermarket and we wait for us to pay for our goods and food stuff that we buy at the supermarket. And then being Malaysians, we can't help but to look at the other counters to see what Malaysians are buying, right? And when you look at the stuff that they buy, I always ask myself, my God, why are they eating this stuff? Okay. Then I look at their body size. I say, my God, it reflects exactly what you eat and what you look like. Okay. And I look at the huge amount of ice cream, the huge amount of carbonated drinks, Coca-Cola, and it is I'm like, this sugar water. I'm like, okay. And you have been involved in public health policy. What are we doing to tell Malaysians that, hey, be careful with what you're eating? Has anybody tell you that these are real bad stuff? But if you go to the supermarket, I tell you, you feel. Your thoughts, please.
Well, Chunwai, I must confess that I have inclination towards chocolate chip mint ice cream as well as raspberry ripple. And, on those days that I want to have one of these, I'm always reminded of, in terms of calories, but also the different nutritional content that's available in these things. And there are so many factors that come into play, when we are talking about these issues. And I'm reminded of the Ministry of Health's National Health Mobility Survey, which was released last year, which indicated that Malaysians generally, a third of the population have a problem when it comes to health literacy. And that is being able to understand the kind of information that's necessary for them to then take on preventative health behavior, like conscious decisions, informed choices, making those decisions at the checkout counter for the supermarket. You don't go for the impulse buy, you don't go for the chocolate stuff, or even, some of the jamu jeruk stuff, So it's really tough because generally what was actually shown is that the Malaysians are having problems not only just understanding the information, but also how it relates to their behavior, meaning there is a disconnect. So even when the information is available out there, they don't see how it relates back to how they live and what kind of behavioral change is needed. Now, if you work in public health, one of the things that you will know is changing behavior is punyalah susah. It's one of the hardest things that you can try to do, and it's the holy grail when it comes to trying to deal things with overweight and obesity. And the fact is that the same survey also showed that more than half of the Malaysian population, adult population, is either overweight or obese, shows that we have a crisis of non-communicable diseases that has at its very roots this issue of being overweight or obese. And the fact of the matter is that liver cancer is one of the long list of other diseases that stems from that issue. And how do we go about helping Malaysians here? What kind of policies? The reality here, Chunwai, and this is the fact is that you can only do so much when it comes to policies. You can come down very restrictive or more like we're doing this for your own benefit or your own health policies, like the sugar tax, that was put into place. But at the end of the day, it goes back to the individual, what kind of awareness and behavior of the individual in terms of wanting to take care. I mean, people like yourself, for example, have already gone down that journey of wanting to take active concern for their health and wanting to change. I did that myself, 10 years ago, I decided to change my own lifestyle and I lost 12 kilos as a result of it, But for a lot of people, the issue of health literacy is a major obstacle for them to go over and to make that change. And it's not just about making sure the information is there, it's whether or not they can understand it. And it's a major struggle. So, dealing with liver cancer, it is one of the issues that we have to actually deal with.
I did the same, like you, Azrul. At some point in my life, I think perhaps 5-6 years ago or more, my sugar level was almost 9 to 10.
Wow.
The doctor says that you really got to do something about it because diabetes will lead to your problem with your liver, and you do not want to die young. And I remember telling the doctor says that you cannot eat any more char kway teow. Then I says I'm from Penang, okay, I can't stop eating char kway teow or nasi kandar or mee mamak.
Yeah.
So the doctor told me straight in the face that you have eaten char kway teow and mee mamak for 50 over years, okay? Can you just stop it?
No.
And yeah, so to control myself, now I'm it's controllable. I'm around 6, okay. Still needs to be done, but I lost a lot of weight. Now I do not take white rice. Definitely that no sugar, no milk. I can do it because that when it hits you, then you really need to think about it. You're not just doing for yourself, but it's doing for your family. So it stuck you. Now, doctor, it has been mentioned that hepatitis is one of the causes for liver cancer. I know that the Malaysian has a vision, the Malaysian government has a vision to eliminate hepatitis C by 2030. How does the government go about it, and is it possible to carry it out?
Okay, so let's look at the bigger picture. So the vision to eliminate hepatitis C is part of the WHO's global hepatitis strategy, which was adopted in 2016 at the World Health Assembly. And really what it is all about is not just about eliminating hepatitis C, but eliminating viral hepatitis itself as a major public health problem. So what it means is that we want to reduce the impact of viral hepatitis. And to be realistic, 96% of the viral hepatitis deaths are due to hepatitis B and hepatitis C. And most of these deaths, almost all, are related to cirrhosis and liver cancer. So what we want to really focus on, if the government is really going to attempt to eliminate hepatitis C, it must focus on achieving the ambitious target which has been put in place in the global hepatitis strategy, which is including 90% reduction of new cases of both hepatitis B and C. That means enhancing prevention. Second is treating 80% of those infected with chronic hepatitis B and chronic hepatitis C. And why these two I actually particularly focus on? Because the studies have shown on modeling figures that if you achieve this target, then you can potentially have a 65% reduction in the deaths related to viral hepatitis, including deaths from liver cancer. So really, when you talked about achieving this, let's look at for hepatitis C. What is the way to do that? So first of all, let's actually quote what the Tan Sri DG of Health has stated in terms of the estimated number of people living with hepatitis C in Malaysia at the current point in time. So based on the data, nearly 400,000 people are infected with hepatitis C. But today, we've only been able to achieve treatment offered to only about 10,000 of people. And that also was more recently because of the availability of the treatment, the oral treatment DAs. But what we need to be realistic is so far, if you look at the number of people living with hepatitis C and the number we have treated so far, it means that we've only treated about 3% of those infected. So we've got a long way to go.
Yes.
So when we talked about wanting to address this, we must address the largest gap in the treatment. And also an equally important gap is also in the diagnosis. So far, less than 10% of the nearly 400,000 of people living with hepatitis C has been diagnosed to date.
Azrul, compared with in Malaysia, I know of many people who do not even go for the annual medical checkup. Some of them are even scared of carrying out a simple blood test. They are worried. I know for a fact that not many Malaysians actually take the trouble to go for medical tests every year. It is a standard practice for many people who are in the corporate life, who understand the need to take care of themselves. I've got relatives who pass away. At least I've got one relative who was a state minister in Sabah, and when he passed away, I found out later that despite holding such a high position, he did not go for a medical checkup, and then it was already too late. People seems to go to the hospitals only when they actually fall sick. And of course, the liver cancer, they will regard it as elective or something that they know. Doctor, you mentioned such high figures, and at the same time, so few have actually been treated. Back to this question of in carrying out this, how much have we achieved and how much have we not achieved in carrying this out?
Okay, so really, I mentioned about the large gaps in both the diagnosis as well as the treatment. But what we need to focus now is what can we do to actually make the elimination an achievable goal. So I think what we need to really focus on is really expand on or scale up on our prevention, the diagnosis, the linkage to care and treatment of both hepatitis B and hepatitis C. So let's start with hepatitis C first. So when we talk about hepatitis C, we need to identify who are at risk of getting infected with hepatitis C. So I think one of the first few things I would always ask if I actually have a patient who's got abnormal liver tests is whether they have got any of these risk factors. So for hepatitis C, I would ask them whether they've received blood transfusion before 1994. And the reason because is that the testing for hepatitis C is only available worldwide in the early 1990s. And in Malaysia, it was in 1993 when we first started routinely test for hepatitis C. So those who received blood transfusion before 1994 are definitely at risk of hepatitis C. And that includes transfusion of platelet when you suppose hospitalized for dengue, when you have got low platelet count. So all those who had transfusion of blood products before 1994 must have at least one test done for hepatitis C. So the other risk factors for hepatitis C include sharing instruments which may contain blood, which means sharing needles of injecting drug use, or unsafe practices from tattooing, for example, or even sharing sharp instruments like razors that may contain blood. And the other situation where people may be at risk are including in hemodialysis centers, because sometimes this cross-infection does take place. But this is rare these days. So hopefully that these practices of actually making sure that there's no cross-infection is going to be enhanced. And that's for hepatitis C. Now for hepatitis B, we know very well that since 1989, we've had the vaccination for newborns. So those who actually were lucky enough to be born after 1989 will have routinely received hepatitis B vaccination when they were born, and subsequently 2 doses after, and that would really protect in up to 95% of cases for people for hepatitis B. But we must remember those born before 1989, like most of us here, are actually at risk if you have got an infected mother who actually may not know that it's infected, because all these are silent infections. So everyone born before 1989 should have at least one test done for hepatitis B to know whether they're infected. So these are for hepatitis B and C.
Yeah, I think that for this hepatitis B and C, now it's quite a standard procedure for a medical examination, right? Medical test.
Okay, for hepatitis B, yes. You will find hepatitis B being routinely tested as part of the wellness package, but it's not so for hepatitis C, because you need to ask specific blood tests for hepatitis C. Because if you go routine screening everyone, the chances of finding is low. So you must only focus on those who have got risk factors. So hepatitis C testing must be specifically asked for. It's not a routine blood test as part of the blood test package. And once you have hepatitis C confirmed, then you need to do further assessment whether or not you need to receive hepatitis C treatment. And we must remember, successful treatment for hepatitis C, we can cure virus altogether and reducing the risk of liver cancer by at least 70%. So this is the most important fact we must do in those who are already infected. They must get treatment if warranted, and get cured so that you reduce your risk of liver cancer.
Azrul, you want to say something? Yeah.
Oh yeah, I just wanted to add on to what Prof. Rosmawati said just now, and to do that, I just want to go back to an earlier point that I made concerning survival, which you alluded to, ChunWai, in your intervention just now, which is that after diagnosis, people don't really survive as long as they should. And for your information, the median survival rate for a person with liver cancer from diagnosis is actually 5.4 months. That's how short it can be. And the reason why is, again, the fact is that people are being diagnosed late. And in order to address this problem, really, we need to narrow the gap from that period of diagnosis. We need to make sure that people are able to be diagnosed, screened and diagnosed earlier. And there are a lot of interventions and efforts that are being done right now. But the reality here is still the fact that we don't look at liver cancer as part of an integrated NCD strategy. I sometimes feel, I don't know if Prof. Ros agrees here, is that sometimes you look at cancer almost like it's individual compartment, you don't put it together with diabetes, with liver disease, with obesity issues. So when you screen, you're not actually thinking about the possibility of liver cancer or liver disease so much, and one of the reasons why is because the primary care level, the GPs, perhaps, they are not really trained in that way to look at it that way.
What Azrul pointed out is actually a very important point, again stressing on the late presentation, and the reason being that these cancers are not diagnosed at the early stage because those at risk who actually may know that they are at risk of getting liver cancer are actually not undergoing a screening procedure or what we call surveillance, repeated tests to show that they may actually have liver cancer, and it may be detected at an early stage if they undergo screening. So what we would like to actually do now is really focus on early detection of liver cancer by undergoing routine surveillance, where we do an ultrasound every 6 months in all those who are at risk of liver cancer. And you detect the liver cancer at an early stage when it's small, you have got a much higher chance of having a cure with having treatment for the liver cancer itself. So another important point that Azrul made is actually the lack of link between having hepatitis and the strategies to bridge the gap between hepatitis and what needs to be done at the primary care level. So what I think we want to focus is how do we explore the link? So now we know that fatty liver is the commonest liver disease and it's associated with diabetes and obesity. We would now look at another opportunity where, for the first time this year, the clinical practice guidelines on the management of diabetes have routinely incorporated fatty liver screening as one of those that needs to be done at a regular interval for all patients with diabetes. So now we have a wonderful opportunity to put liver disease and liver cancer on the radar of not just endocrinologists, but also primary care practitioners. And we can now integrate more like a public health approach to liver disease and liver cancer into primary care, because the primary care practitioners or GPs are often the first medical professional that the patients see with diabetes and also fatty disease. So I think we need to also show that the fatty liver disease are also an NCD, another component of NCD, and it is the liver manifestation of metabolic syndrome, which is the commonest cause of NCDs. And now we can integrate and have a better opportunity at the primary care level to improve on the prevention, detection, as well as treatment of liver disease and liver cancer. So bridging these two gaps are important.
in terms of benchmark, how do we compare ourselves when we talk about integrating the management of liver diseases from prevention to treatment? How do we stack up? You have mentioned some of the things that we should do, but what would be the best comparison to countries that we're familiar with, Azrul and Doctor?
Prof, go ahead.
Okay, so when we talked about integrating, I think we are still at a very early stage, but it is already a first step. We are one of the few countries in the world who has introduced this routine screening among patients with diabetes. So I think that's a great first step. But what we need to do now is optimize a lot more screening available, because once a primary care or GPs know to look out for liver disease, then the other screening for the other liver diseases can also come in, because once you have an abnormal liver test, you're not going to stop there and say this is due to fatty liver. You have to exclude hepatitis B and hepatitis C. You must assess the severity of the liver disease and then find out who amongst those with liver disease are at risk of liver cancer, so that routine surveillance or screening for liver cancer can be done. So I think we have got this opportunity, and let's make full use of it and integrate the knowledge and the tools available already to incorporate this at the primary care level.
If I could just add on, one of the things that was very important for us to realize, and I think sometimes we forget this very important point, which Prof. Rosmawati alluded to earlier, concerning liver cancer surveillance, is that if we don't have more effective liver cancer surveillance, the fact is the late presentation of liver cancer today is not going to be changed, So we need to empower the primary care health providers to be able to adopt many of the new changes that are happening, such as those in the clinical practice guidelines, which was mentioned just now, into what they are seeing at the primary care level. Because GPs are everywhere. There are more GPs than there are hospitals and clinics that are dependent on by the government. So if you imagine that the GPs are your fingers or the networks into the different communities, those guys will likely be able to see the presentations of liver disease much earlier than at the tertiary level. By the time you get to a hospital, it's probably late already, and there are fewer options going to be available for you in terms of treatment. It's going to be harder to treat the disease. So empowering and building capacity of the GPs is going to be key here. And that's a very important point. But I wanted to mention about Project ECHO, which I think Prof. Rosmawati has on her background banner there, which is a very interesting project that looks towards bridging the gap between urban and rural communities, because we have that problem. If you look at cancer-related facilities in Malaysia, it's quite stark. You see most of the cancer-related facilities on the west coast of Peninsular Malaysia, nothing on the east coast of Peninsular Malaysia, except for maybe Kubang Krian, and that's it. And very few places in Sabah and Sarawak, that are able to do. So you have basically major gaps in terms of coverage of these services that are necessary. So in order for someone to get a diagnosis of cancer may result in that person having to travel hundreds of kilometers down to a major hospital in order for that person to be able to get screened. So Project ECHO is really something that is interesting, came out from I think University of New Mexico a couple of years back, basically trying to ensure that the level of capacity to diagnose these diseases in the rural setting is going to be the same as the urban setting. But essentially right now, what we need to be able to look at in addressing these gaps and challenges when it comes to liver cancer or even cancer in general in Malaysia is really recognizing that there is a disparity between the urban and rural areas, especially when it comes to cancer. Because if you think the middle class or urban areas are having a tough time with cancer, liver cancer especially, you can imagine what's happening in the rural areas where most of these cases are perhaps going undiagnosed, definitely untreated, and as a result, people are dying as a result of this particular disease, which is why our mortality rate when it comes to the liver cancer is quite miserable, and it can be improved upon. We should be able to save lives with earlier prevention, but also better and effective treatment.
Yeah, Doctor, before you dive into this subject, I think that Azrul, you have brought up a very interesting and very important part. Both of you have talked about the how the GP will be the first person that is in contact and to give a diagnosis. Even a full medical test, your full medical blood test, covering everything, it's not really cheap. Okay, and most of us who has gone for checkups in hospitals for liver, for example, it is really, really costly. And we know that in Malaysia, even the M40 is sliding down to B40. Don't talk even about the B40. How many people, if they feel that they are okay, they're not sick, will actually take the trouble to go for this full medical test, and it is costly. And how do we handle such a problem if people do not really go? Not because they don't want to. It's just that they think that, look, I could save a few hundred ringgit for something else. So how do we tackle this early detection and early awareness, Doctor?
Yeah. So I think what we need to do is targeted screening. So we cannot go across the board to actually screen everyone. So targeted screening is important. So it's really, it should start with targeted screening of who are at risk. So we've mentioned just now about who are at risk of hepatitis C. We've mentioned who are at risk of hepatitis B, but we have not quite really focus on, again, the commonest liver disease that they will be saying, which is a fatty liver disease, which is not due to alcohol. So what we actually would like the general practitioners to do is they can start with a simple blood test. And a simple blood test means it's a simple liver function test. And this is not expensive. And it can be done in most of the clinic kesihatan for the B40s. At the GP level, it can also be done. And Azrul is right. We have nearly 8,000 general practitioners nationwide, which can be roped in helping to actually do this screening for liver disease. And what Azrul also pointed out is the ECHO project, which is something which has been, which stands for the extension for community healthcare outcomes, and the C, which is another color you can see in the background, stands for hepatitis C because it was started for hepatitis C in the University of New Mexico by the founder, because he wanted to have more patients having treatment for hepatitis C at that time with interferon, which is very difficult to be done at the GP setting because it's injection. But he managed to do this by using multi-point video conferencing. But we are very comfortable now with the pandemic to be using all the digital technologies or platforms, and we can now have this knowledge sharing network, and this is led by an expert. You can be anywhere, you can have more than one expert, you have multiple experts who actually will connect with the other providers at the rural setting, for example, for GP setting, or even other non-doctors, because the non-doctors can also help to have reflex testing, for example, for those who are at risk of liver disease. So what we would like to actually get from this, it is a capacity building model. And this is really about tele-mentoring the GPs or primary care providers to provide best practice care using simplified algorithm, and then only refer complex cases. So most of this can be done at the periphery, decentralizing most of the testing and treatment at the primary care level and only referring complex cases. So it will keep costs down, and at the same time, you empower a lot more primary care providers to really be the assistants in terms of both screening and also treating liver disease. And this can be done because it has been started for hepatitis C even at the clinic kesihatan level. So we need to actually get a lot more GPs involved in this process.
When we talk about cancer of any kind, okay, including liver cancer, it is always referred to as the big C. When you tell people that I think I've got cancer, everybody gets very worried, they become stressful about it. But of course, that there's been a lot of advancements in terms of treatment. Can you share with listeners who are following this program, look, this is not the end. This is not the end of the road. There's really hope if you are detected early. What are the advancements in technology and treatment?
Well, let me just say, Chunwai, one
Yeah.
of the reasons why we're harping quite a bit on early screening, diagnosis, of course, prevention is definitely key. But most importantly here, especially if you're in the risk categories, for there to be deliberate efforts to screen as often and for you to get early diagnosis, is because the reality here is that we are limited by what available treatment there is. Okay, so the later that you are diagnosed and the later you are in terms of your disease progression, there are fewer options. And the fact of the matter is, for Malaysia, there are so many of these deaths that are premature, that did not have to happen, that could have resulted in people having a much more prolonged life, but most importantly, lives also being saved. Yeah. And a major part of that, if you look at the fact that more than 70% of cases in Malaysia, cancer at stage 3 and 4 are detected, 70%, which means there are fewer options there that are available, which is why it's important for some of these issues that we're raising through this discussion right now, especially in terms of empowering GPs to be able to recognize the early indications of liver cancer, but also progression of liver disease and so forth, is to be able to catch it earlier. And when you have it earlier, when you catch it earlier, you are going to be able to have treatments that are available that will be able to help provide their better health outcomes for the individual, but also most importantly, survival. And there are advances in treatments that are happening pretty much every other day now. There are new advances, but we're still limited by at what point is that person being diagnosed. So the reality is, in developed countries, we are seeing cancer as a survivable disease. To a very large extent, there have data that looks at 5-year survival rates, which are far better than Malaysia's, far, far better. And the reason for that is really because of availability, not just because you are able to screen and diagnose earlier, but also the availability of effective treatments in those countries as well. And that is where we need to make sure that that formula works in Malaysia as well. It's not enough that we are also able to push the prevention message out, make sure you don't even get to the point of developing the disease. But even if you do try to catch it earlier, we also need to make sure that people do not get left behind simply because there's no treatment available. And that's a difficult formula for us to sometimes compute there, because we look at budgets every year. Yes. I'm sure Prof. Rosmawati does this every year. We're looking at the TV screen at budget being presented by the finance minister, scratching our heads, wondering how much are we going to get, what's the oncology budget, and all these things, and it's quite unnecessary, I believe, because we need to reform the way we look at financing of the treatment of diseases like cancer, and right now we're sort of stuck in a model. Every year we're doing the same thing and we're not getting better outcomes. Here's the thing, ChunWai, if we were doing the same thing, we're getting better results. That's great. The reality is it's getting worse every year. And we need to change the way we do things right now, especially when it looks like we are depending on a lot of exemptions that are given to Malaysia as a country that looks at cancer. And the fact of the matter is, we are heading towards trouble. Malaysia is going to be a high-income country soon. The Prime Minister said it the other day during the tabling of the 12th Malaysian Plan, and he said that in 5 years we're going to be ending up as a high-income country. Can you imagine what the different kind of levels, expectations, the kind of exemptions or carve-outs that we've been able to have as an upper middle income country? They'll all be gone when we enter high income country status. And we need to plan for that future, because we cannot have our people, Malaysians, people here living in Malaysia, being left behind simply because we say, I'm sorry, we can't afford your treatment. You know, we need to be able to think beyond this box that we put ourselves in. And that's why today there's a lot of discussions about not just about screening earlier, diagnosing earlier, but also getting value, you know, in what we invest in. And when it comes to healthcare, it is about investing in health, not spending on health,
Correct.
investing in health, and it includes saving more lives through effective cancer treatment.
Dr. Rosmawati, we have to wrap up the program. You will have the last say. Here. The lady has the last say.
Absolutely.
Yes.
Thank you. But I want to be positive, and I think there has been exciting development of late for liver cancer in terms of treatment options. So all what we've been saying that was prevention is important, but if you already got liver cancer, hopefully you are diagnosed early and can get offered treatment which can prolong survival. And we do go by the evidence-based approach to treating liver cancer. So one of the things we have to really remember at the end of the day, that when we talk about the burden of liver cancer, we really need to think how we're going to approach it overall, and that is to reduce the burden not only by prevention and control of viral hepatitis, but we must also curb the growing epidemic of obesity, diabetes, and fatty liver disease.
Thank you, Dr. Rosmawati and Azrul. To viewers out there, the things that have been mentioned by both our panelists, early detection, early screening, and there's advancement in treatment. So don't give up hope. If you're watching this program and you need to have treatment, just go ahead with the treatment. Please remember, even the word hopeless starts with the word hope. On that note, thank you and good night.